Hello, and welcome to today's webinar on mental health policy. I'm Avenel Joseph, Vice President of Policy at the Robert Wood Johnson Foundation, the nation's largest philanthropy dedicated solely to health and health equity. The foundation is 50 years old and has from the start been a trusted and nonpartisan source of information on policy aimed at improving health and health equity. We partner with others to develop a culture of health, where everyone has a fair and just opportunity of health and well-being. Today's conversation will focus on the current mental health crisis facing the United States and how policymakers can support mental health at the national, state, and community levels. Mental health issues have posed a serious risk to communities for years. In 2019, nearly 20% of adults in the United States, roughly 50 million people, experienced a mental illness, according to Mental Health America. Over half of those struggling did not receive mental health treatment. The COVID-19 pandemic, as all of us know, significantly worsened this crisis. Rates of depression, anxiety, and other mental health conditions skyrocketed over the last 2 years, particularly among young people. According to the Centers for Disease Control and Prevention, more than 1/3 of U.S. high school students reported experiencing poor mental health during the pandemic. 44% reported feeling persistently sad or hopeless during the past year. The increase in demand for mental health services has severely strained the United States healthcare infrastructure, forcing individuals, many of whom are in crisis, to wait months for appointments and other services if they receive care at all. Policymakers have taken preliminary steps to support mental health, including launching 988, the national mental health equivalent of 911, increasing support for school mental health and safety programs, allocating funding for certified community behavioral health clinics in every state, and investing in behavioral health training for primary care providers. More resources are desperately needed. There are concrete steps policymakers can take to bolster the nation's mental health system and ensure resources reach the communities that need them most. To discuss this in greater detail, I'm pleased to be joined by two terrific speakers. First is Vicki Wachino, principal at Viaduct Consulting and executive director of the Health and Reentry Project. She is the former deputy administrator of the Centers for Medicare and Medicaid Services, CMS, where she oversaw policy and operations for Medicaid and the Children's Health Insurance Program. With that, I'll turn it over to Vicki.
Avenel, thanks so much. And thanks to RWJ for convening this conversation. It is, as Avenel noted, a critical time for mental health and an opportune time to be talking about the opportunities going forward for policymakers to make a difference. We can jump to the first slide. And what I'm going to do in my presentation this morning is really start with talking about the behavioral health challenges that our country faces now, then move to how we cover and finance behavioral health in our nation as a bit of a level set, and then talk about recent legislative activity, both things that have been enacted and laid the foundation for behavioral health policy, some of the issues that are on the table, and then end with where we might go from here. As you'll see on this first slide, the facts are unfortunately stark and illustrate the extent of the crisis. Rates of suicide have gone up more than 1/3 over a recent 20-year period, and each year, deaths from overdoses increase and break new records. And most recently, even those of us who follow the space closely were concerned when we learned that in a 1-year period, overdose death rates for adolescents doubled. And the death rate for Black male adolescents outpaced even that, tripling. So we really are in a state of crisis in the country. And although COVID exacerbated many of these factors, it's not the driving force. The driving force are underlying issues in mental health that have been with us for some time that COVID exacerbated. And for that reason, I think it's important to look beyond the headline statistics on suicide and overdose death rates and look at some of the longstanding challenges that our health system have faced. Let's start with increasing rates of mental illness. And as you see on the slide, they've gone up 15%. But if you dug a level below that, you would see that nearly all of that increase is driven by rates of mental health conditions, specifically for teens and young adults. So to the extent that we have a crisis, the crisis is particularly acute and driven by increasing rates of mental health challenges, specifically for kids and young adults. And then pivoting from there, we've had longstanding challenges in the country with not meeting the needs of people with mental illness when they have mental illness. So 50% of people who need mental health treatment don't get it. And the rates are much higher for people who are Black, for people who are Hispanic, and people who are Asian or Pacific Islanders. Those rates climb into the 2/3 to 3/4 rates. And those are issues that have been with us a long time. They predated the pandemic, and they will be with us after the pandemic. It's also important to think about mental health as where it stands as a real intersection point for multiple systems in our country. So these rates of mental health challenges affect our health system, where at least half and as many as 90% of people with a serious mental illness also have a significant health condition. They affect our criminal justice system because 40% of people in prisons and jails have a mental health condition and upwards of 60% have a substance use disorder. They also ripple through our housing, education, and employment systems. So I like to say, no matter what issue you care about mental health because it's affecting the performance of major parts of our society, country, and economy. Next slide. When we think about what are the levers that we use to make sure that people have access to services, the health system is really the powerhouse of ensuring that people's mental health and substance use needs are met. As you can see from this slide, private insurance and Medicaid finance the largest shares of mental health and substance use disorder treatment in the country. And smaller programs, grant funding, state and local funding also play a role, but to a significant degree, mental health and substance use disorder are the responsibility of the health system. And I should say, the data wonk in me compels me to say that if you looked at slightly different data sources, the Medicaid piece might look a little bit larger. And there's robust debate among those of us who follow these issues about whether private insurance or Medicaid are playing a bigger role. But at the end of the day, and you can choose your data source, they're roughly comparable. Next slide. Congress has a longstanding interest in advancing mental health policy. Two laws really lay the cornerstones of how we address mental health in the 21st century. The first is the Mental Health Parity Act, which required insurers to cover behavioral health in a way that's comparable to coverage for physical health. That was passed in 2008. And shortly thereafter, the Affordable Care Act baked parity in to behavioral health services and extended those services both to many people who are funded by private insurance and to many people who are covered through Medicaid. And as a result, where we stand now as a country is many more people have access to behavioral health services through their health insurance coverage than ever before. And over time, Congress has acted incrementally to advance access to behavioral health services. The 2018 Support Act focused specifically on opioid overdose, the opioid overdose epidemic. Block grant funding and telehealth have been a key part of the COVID response. As you'll hear a little bit more in a moment from Ken, the new crisis call line 988 is being implemented now. And most recently, as part of the Bipartisan Safer Communities Act, which is the law that Congress enacted in late June following the Uvalde shooting, which primarily focuses on gun safety, there were significant new investments made in mental health. Investments in expanding certified community behavioral health centers, which are one model of addressing community needs, additional funding for 988, and some grants and new policies to promote Medicaid's ability to cover kids in schools. Next slide. But for many members of Congress and policymakers, there's a sense that the work is not by any means done. We started the year with a major policy focus on behavioral health, and it's really carried through. And whether you look at what the administration's priorities are or what Congress's priorities are, it's very clear that mental health is front and center for many policymakers. And even if you just, as many of you do, participate in congressional hearings, it seems much more common now to hear directly from members in Congress about family members who are affected by mental illness or eating disorders or addiction issues. And many members seem to have a really personal stake in the issue. And it's really welcome to hear people being so transparent with the way this is impacting their families and communities. The year started with the president announcing the mental health as a priority in the State of the Union, and he followed up shortly thereafter, releasing a very comprehensive set of proposals. And since then, we have seen action in nearly every committee with jurisdiction moving forward in behavioral health, whether it's appropriations or authorization. This has been a priority through the year, and it remains possible that Congress may add to its investments that it made in the Bipartisan Safer Communities Act with legislating later this year. And obviously, we've got elections and other things on the legislative calendar that could become that influence whether action will be taken. But I think there remains a clear interest. And this slide really kind of synthesizes the key areas that have been areas of focus on a bipartisan basis. And it's worth noting that when Congress has acted on mental health, most of the legislation has been enacted on a bipartisan basis, and there seems to be a clear commitment to acting in a bipartisan manner this year on the part of both the administration, which made its proposals as part of a broader unity agenda, and on the Hill. And if you looked across the various proposals that have been made, there's been a strong focus and needed focus on how do we better meet the mental health needs of kids and young people? How do we enforce mental health parity laws to make sure that we're really realizing the promise of treating behavioral health and physical health in the same manner? A lot of concern about the behavioral health workforce. Some of those concerns are longstanding. Some of those concerns were exacerbated by the COVID pandemic, which really hit behavioral health providers, which tend to be small community-based providers, hard. How do we integrate care into the healthcare system so that providers, and particularly primary care providers, see meeting mental health needs as part of their jobs and are supported in doing that job by having ready access to behavioral health services? And finally, how do we learn from the flexibilities that we provided around telehealth during the COVID-19 pandemic, where we became much more flexible and telehealth became a more widespread tool for providing both health and behavioral health services? As we think about the end of the pandemic, how do we bake some of what worked with regard to telehealth into the way we provide behavioral health services? And where are the places where we need to make improvements so that we do it better? So finally, I'll just end with noting that we can think more broadly about behavioral health. And if we could just jump to the last slide, there are still places where, although there's been so much attention to mental health and substance use this year, there are still some places where we could put some shoulder to the wheel and challenge ourselves to do more. I think the biggest picture question that we face right now is, given the magnitude of the crisis, what should the magnitude of the solutions be? Overall, there tend to be solutions. We tend to be talking about solutions that total in the $1 billion range, right? And you can see the appeal of that, right? It's a little bit lighter on the federal wallet. You're more likely to get bipartisan support. On the other hand, it may be the case that we need more significant investments in order to really move the needle to address trends that are escalating rapidly. Second, we need to challenge ourselves as a healthcare system to really ensure equity in the provision of behavioral health services. And underneath every national statistic on mental health and addiction, if you dug down, you would see some pretty deep fissures between white people and people from other races, between straight people and people who are LGBTQ. There's some real challenges. And I think that part of our challenge as policymakers is to really figure out how to move the needle for vulnerable populations. Finally, we tend to think about ensuring access and strengthening workforce as solutions that can be solved solely with grants and loan repayment. And those are absolutely vital tools. But to really build towards a system that ensures strong access for everyone, we need to look long and hard at the way that the health system is covering and paying for services. The path towards long-term sustainability of our behavioral health system runs through the healthcare system, and the services we cover, the providers we cover, what we pay and how we pay are the essential ingredients to long-term plans for a behavioral health system. And then finally, focusing more on how do we meet people early in their onset of mental illness? How do we prevent mental illness? It's very common for us who work on the health system to talk about prevention. We've really pivoted our health system approaches to preventive approaches, and we need to challenge ourselves to develop policy to do the same in mental health. Some of the interventions, some of the research, some of the evidence base points really strongly in that direction. And what we haven't yet followed that with is policy tools that advance behavioral health. So I'll just conclude by noting that I started by noting that the challenges are not small, they're big. But the reason to be optimistic is that there's policymaker attention now, and that I think will be sustained over time, and that has the potential to yield benefits for not just the behavioral health system, but the health system, the criminal justice system, the housing system, and many of the sectors that try to deliver for the American people. Thanks so much, Avanel and RWJ.
Thank you, Vicki. That was a really fantastic foundational presentation. So now we're going to turn the stage over to Ken Zimmerman. Ken is a founder and the co-director of the Mental Health Strategic Impact Initiative, or S2I. S2I is a think and do tank that works to ensure all people with mental health conditions can live the fullest possible lives in the community of their choice, and that public and private systems and resources are equitable and effectively devoted to that end. With that, I will turn it over to Ken.
Thanks, Avanel, and thanks to RWJF for hosting and inviting Vicki and me to participate. Just by way of introduction, I bring several perspectives with me, including my professional work over decades as a civil rights lawyer and policymaker focused on housing and homelessness, criminal justice reform, and an array of other things, from posts in the federal government, state government, running a philanthropy, et cetera. But I want to note and bring into the room a very personal perspective that I bring with me, the perspective of a parent who lost a child to a serious mental health condition. So it means, when I say thank you to Avanel and RWJ, to all of you for your interest and participation here, that it's a deeply personal one, and unfortunately one in which our experience is shared with millions of Americans, and makes the attention that you all are giving to it something that has deep resonance. So thank you. After Jared died in his early 20s, a bit over 6 years ago, I spent a year going around the country to understand why our nation's approach to mental health was so broken. And I came away with two fundamental starting points. First, the system, if you can call it that, is as deeply challenged as our own experience suggested. But second, and I think this is the reason for hope, not only was there increasing attention and interest in doing something, but there are really promising ideas, pathways, and seedlings of change. And one key takeaway that was incorporated in what I learned is that it is essential to build in an equity commitment from the get-go. That's not only because it's the right thing to do, even though it is, it's because only in that way can we actually build what virtually every American family needs and wants, which is the level of support, the level of attention, and the level of ability to see for family members, friends, and others who are suffering with mental health conditions, the pathway to recovery. So to take one example, in one of the more astonishing facts that exists in our mental health reality right now, it takes on average 11 years from the onset of mental health symptoms, of serious mental health conditions, to the accessing of treatment. Think about that for a second, 11 years. Certainly if it were cancer, if it were diabetes, it is something that we would take seriously and attend to. But from an equity perspective, think about what that means in terms of focusing upon communities of color, rural communities, LGBTQ. In each of those situations, we need to delve deep and ensure that we are attentive to the equity dynamics of solving something like that. So thank you at the outset, and let me spend my few minutes on building on what Vicki presented by noting 3 points, and then talk about the specifics of behavioral health crisis reform as an equity opportunity. So just as at the outset, these are the 3 things that I'll delve into in greater depth. The first is, what are the major disparities? They include race, place, and more. Second, to delve a little bit further into the context of why they arise. And I want to just note that, as these examples on the slide suggest, it is really important to understand that addressing mental health and the mental health supports that are needed certainly include and start with health supports, but only start there and extend far more broadly. In fact, the leading evidence suggests that only 15 to 20% of what's needed to meaningfully address mental health and mental health treatment comes from the health system. And the rest include the kinds of things around housing, education, workforce, and the rest that are notable. And similarly, they also incorporate, in terms of triggers and catalysts, the experiences of discrimination, violence, and other things that we all understand as potentially connected to mental health and mental health supports. So as we think about where we can go, and I'll touch a little bit more deeply on this in a second, one of the real exciting opportunities of the moment, as Vicki suggested, is that there's increasing attention in a broad array of areas. Some of this is about things like adverse childhood experiences, ACEs as they're known, and trauma-informed care, in which there's national efforts led by the CDC and HHS, including Interest on the Hill, about how to incorporate them. There's a deep prioritization of mental health equity. But even more, there is growing recognition that being attentive to lived experience, to the ways in which people who've experienced mental health conditions can contribute, not only because they have an interest in doing so, but they are bringing innovation and they are bringing ways of addressing it that otherwise wouldn't come to the fore. As an example, the so-called peer workforce, the idea of incorporating people who've experienced mental health challenges into the workforce crisis that we have. There are now over 30,000 peer specialists with a strong evidence base about how important they can be, and with the beginnings of financing through Medicaid and elsewhere in a number of states to certify their participation. And that's only one of a number of examples. Next slide, please. So in terms of the disparities, the evidence is very clear-cut about where in greater depth certain communities are more significantly challenged. With regard to communities of color, as Vicki noted, with a 57% rate of untreated mental health conditions in the general population, it moves up to 2/3 and even more among communities of color. Even more significantly is there are differential outcomes when treatment is provided. The evidence, for example, establishes that Black Americans, especially those with serious mental health conditions, are far more likely to end up as incarcerated than non-Black Americans are. And this is against a backdrop of a history that's very problematic, reflected in the APA's apology to Black people for past practice last year. And it also is reinforced by the significance of incarceration, a reality that our largest mental health institutions are still the jails in LA, Chicago, and New York City, and the workforce diversity. Less than 2% of all psychologists in the United States are people of color, and that raises real concerns about cultural competency, comfort in terms of who would seek treatment from whom. I also want to emphasize, though, that the disparities are not only about demographics. Rural populations face huge challenges as well. There are over 150 million Americans who live in what's known as a mental health professional shortage area. 60% of those are in rural areas. And I had a first-person experience where I was asked to talk in North Dakota at a high school that had had a suicide epidemic, with 20 children in the 200-kid high school having attempted suicide in the past 2 years. And what was striking about that experience is that the nearest mental health professional was over 75 miles away. Think about that for a second in terms of what it means in terms of trying to provide services there. And what that limited infrastructure suggests is the importance of increased roles for schools, for primary care physicians, as one of the means to address the challenge that exists. In this regard, telehealth is absolutely critical as a way of expanding the availability of workforce. At the same time, it means we need to be thinking about broadband and other similar types of ways of supporting that. And that in part is to address the suicide rates that are unparalleled in rural America right now. It's also important just to note how much LGBTQ youth and veterans are other populations that need specialized attention. So against this backdrop, next slide, please. I want to offer a particular experience or area that I think is ripe for serious equity attention, and it exemplifies what otherwise might be done. Both Avinal and Vicky mentioned 988 as something that is a new approach to mental health for behavioral health crises, behavioral health emergencies. And just to put that into some context, it has been known and universally acknowledged for a considerable period of time that when somebody is experiencing a behavioral health crisis, whether that's a mental health crisis or substance use crisis, the calling of 911 and largely ending up with either police, jail, or emergency department as the effective response is ineffective and it's inequitable. And the significance of that recognition is not only among individuals who needed to access those services or family members, those who support them, but law enforcement who understands this is not the role that they want to be playing, emergency departments of hospitals. In other words, the broad-based and bipartisan recognition is leading in a very potentially exciting way to a revamp of one of the key elements of the behavioral health system in terms of what might allow people to access services. And the way that it has been approached is that there are three key elements that have been identified: somewhere to call, 988 being the new establishment, someone to come, mobile crisis teams, and somewhere to go, receiving centers. And that is what the federal government has started to begin to deploy with increased funding, as Vicki mentioned. In looking at this from an equity perspective, however, one of the things that S2I did is begin by talking to people with mental health conditions, with racial equity experts, about what else needed to be incorporated in thinking about the behavioral health crisis continuum. And what begins to emerge is that as critical as those elements are, it's equally critical to make sure we're attentive to other dynamics. Prevention, as Vicki indicated, is absolutely critical. Post-crisis connection to services, and that requires going deep into the experience of African Americans and other people of color, going deep into how rural communities need to respond given their limited infrastructure. And so some of the equity opportunities for the federal policymakers to consider include the establishment of guidelines and standards that states and localities, huge numbers of which are beginning to implement programs in a variety of ways, can and should provide minimum quality standards for all Americans, regardless of their starting point. The importance of data disaggregation and equity metrics that would guide the way in which crisis services are provided, and the establishment of a culturally competent workforce. In that regard, the ability of peer specialists, as an example, especially peer specialists of color, to participate, and in this regard, on tribal communities and elsewhere, is something that is starting to be developed, but can be expanded upon in really important ways. And in doing all of this, to have the engagement of community voice and lived experience. So I'm going to conclude and open it up for questions by just noting that this is one of those examples of how the potential of this moment, in terms of the broad recognition across the aisle of the opportunity for change, we can and must build in equity from the get-go in order not only to do the right thing, but because that's the way we're going to build the effective policies and practices of the future that the American people both expect and need in this moment where there is so much mental health challenge among so many people. Thanks. And with that, I'll turn it back to Avinal.
Thank you, Ken. You and Vicki provided important reminders of the foundational role that mental health plays in overall well-being and the importance of investing in affordable, accessible, and equitable mental health care. We will now take questions from the audience. To ask a question, please type it into the Q&A box on your screen. We already have a few questions coming in, and the first I'll start with is this: are there any states or programs that are particularly good examples of innovative solutions to mental health challenges? And if so, what are they?
It's a great question, Avinal, and I think that there are lots of states, but I'll just choose three that have stood out to me recently. The first is California, which has used a combination of federal policy levers and its own resources to really start moving the needle forward in a behavioral health system that is extremely complex. So they've made significant behavioral health infrastructure investments to try to overcome longstanding access challenges. They have made it easier and by removing administrative barriers to people receiving behavioral health services, with a particular focus on getting kids access to services. And another thing that they've done is they're one of 9 states that have asked the federal government for permission to cover people through Medicaid coverage at reentry, which really has the potential to move the health and behavioral health needle for a vulnerable population. So those are just a few of the things that California has done recently as part of a much broader commitment to behavioral health. Ohio stands out for a couple of reasons. One is they're pioneering a managed care approach for kids with very complex needs, kids who are affected by multiple systems, Medicaid, the child welfare system, and really focusing specifically on the needs of that population. I think that's really promising. And as you may hear from Ken, they also have a very strong approach to crisis care. And I'll let Ken say a little bit more about that. And finally, Arizona. And what's notable to me about Arizona is that over the past 10 years, they've really moved to break down bureaucratic silos so that their health agency and their behavioral health agency have become integrated. And that sounds somewhat technocratic and wonky, I know, but really integrating the state level responsibilities had laid the groundwork for perhaps the most meaningful integration of behavioral health and healthcare that we see across states. They've leveraged their Medicaid program and their grant programs to make progress in behavioral health along a number of fronts: crisis care, reentry, and other areas. So those are 3 states that stand out to me. Ken, what would you add to that?
Well, thanks. You took a couple that I was going to mention, but let me add to that. One, I would note Washington State right now, where the governor has made behavioral health a priority in really 2 regards that I would note. One is workforce, where they are seriously expanding attention to not just peer specialists, but looking at ways that community health workers and non-professionals can become a key part of the workforce in a variety of dimensions. And I think both on an equity perspective, but also on a broader workforce capacity perspective, the idea that not all of the treatment needs to come from psychologists and psychiatrists, even though they're essential, but there are many others that can be expanded. And the state is taking that on in a very significant way. Second, on the parity point that Vicki made, in the crisis context, they passed legislation that is looking at the ways in which private insurers should be covering many of the crisis services as well as the public financing. And I think both of those are illustrative of the ways in which certain states are taking a lead. The second state I would note is Texas, which in many respects, not all, but in many, is undertaking a variety of innovative programs. As an example, in terms of youth mental health crises, they have authorized the state medical schools, and particularly their psychiatric units, with the advent of telehealth, to become resources for K through 12 public education, noting the absence of people who, professionals who would be available, and recognizing that there's increased capacity that can be existed and brought together in ways that are hugely necessary and reflect, I think, a level of innovation that can be adopted. And then finally, I do want to note Ohio in the crisis context. Governor DeWine made ensuring that there is an effective and comprehensive crisis continuum in the state a priority, and is following through on that in a variety of dimensions, including having multiple localities pick up new and important innovations in developing crisis response, but at the state level, beginning with 988, but not ending there, ensuring that state financing and policy support, not just in the mental health arena, but in the health financing, in the law enforcement, in the criminal justice arena, are all brought together to ensure that that kind of comprehensive support is actually delivered on the ground.
Those are great examples with some varied approaches, so I appreciate you highlighting those. Our next question is, the pandemic has had a particularly profound effect on children's mental health. What opportunities are there for policymakers to support kids?
I think it makes a lot of sense to focus on kids right now, not only because they are so affected by our nation's mental health challenges, but also because my experience in the health system shows that when we invest in kids, we see returns that ripple through generations. Kids that we intervene early with are more likely to stay in school, to learn, and to grow into healthy adults, to go to college, and to participate in the workforce. So I think that there's a strong return on investment in focusing specifically on kids. 3 things I would call out. First, we need to meet kids where they are. Their access challenges are significant, and we need to do a better job of going to them. Schools, meeting kids in schools and expanding health services in schools is one way to do that. Congress has provided significant grant resources to advance mental health in schools. Some of those grant resources were just released this morning. And as I mentioned briefly earlier, the Safer Communities Act includes a very promising provision that would expand the ability of Medicaid to cover services in schools. It requires new guidance, grants to states, and creates a TA center. So the federal government's actively helping state Medicaid agencies and state school districts advance Medicaid coverage. And I think that, frankly, has the potential to be transformational, depending on how HHS implements it. Second is prevention and early intervention and expanding some evidence-based practices. One example is home visiting. Home visiting is an evidence-based practice where we intervene in the home through a nurse or other practitioner with a new mom and a new child. And it has a great evidence base in multiple domains, including mental health. And it's something that I think needs to be more frequently covered by insurance programs to really spread the promise of that intervention to more people. And third is integration. I talked earlier about the ability of primary care providers to provide behavioral health services. And I think pediatricians are up for the challenge. And if they were able to move the needle for pediatricians and kids, that will then be able to spread that from other practices there. So within integration, I would start with kids. The last thing I'll just note before handing it back to Ken is that Medicaid plays a very huge role for kids in America. It covers more than half of the children in America. So if we want to improve the mental health of kids in America, we need to start with Medicaid and really push it forward to make sure that we're helping kids realize their full potential.
Let me just add 2 points. One is to remember how much not only is the investment in youth mental health significant because of the long-lasting nature of those investments, but mental health is in some respects a young person's disease in the sense that the onset of serious mental health conditions, 50% occurs before the age of 16 and 75% before the age of 24. So the interventions and investment in that kind of attention is significant because it actually is the way in which we address and improve life outcomes for so many people. And all of the aspects that Vicki noted are ways of doing so. I just want to add to it that one of the ways in which it's so important for policymakers to link the financing with the intervention points of taking kids where they are is that we need to be attentive to how we're going to provide support for schools, not only school teachers and counselors, but for other staff in schools that have not historically been assigned or expected to have these kinds of roles. And the Texas example I gave is only one of a number of kinds of innovations. So it's going to be critical, similarly with primary care physicians, some of the new collaborative care models and other ways that we can redesign how we're financing to ensure that we have a comprehensive approach that brings in non-mental health professionals to do some of the early intervention, some of the screening, I think are areas of great opportunity.
That was great. Thank you. We have a number of really fantastic questions that are coming in this morning. So I'll move on to the next question. What are some non-medical interventions that individuals can use to improve mental health and advance health equity within their local communities? So I think this question is getting around engagement, right? Like what sort of things can individuals do to help improve situations in communities?
I'll start. I mean, the first, quite frankly, is to speak up and speak out. We are at a time where part of the opportunity exists because the historic stigma around behavioral health issues, both mental health and substance use disorder, is diminishing. It's diminishing because of brave people like Naomi Osaka or Simone Biles and a number of others. But in local communities, it's because people are speaking up and speaking out about their own family's experience. And there is no replacement for that as a starting point. Beyond that, there are numerous local organizations, both on an equity standpoint and more broadly from NAMI and Mental Health America, that are organizing to be support to each other and to reflect how significant this issue is. And I think those are critical. I would also say that because of the universal nature of it, for those who are committed to other issues, whether it's housing, whether it's education, whether it's seeing equity throughout all of those is to ensure that mental health is brought into those conversations just as much, recognizing the fundamental linkage. So there's a place for everybody in terms of doing their part, whether it's at the federal policy level or whether it's at local communities. And it's part of the reason why, I think the trajectory of potential transformational change is almost unprecedented right now. The reason why I hope everybody leans in and recognizes the opportunity.
Thank you, Ken, for that inspiration. Next question, how can policymakers improve access to culturally competent mental health care? What programs are available to diversify the mental health workforce?
I think cultural competence and diversity are really key challenges in our workforce. And there are different levers that one could use. It's historically, and we are currently turning to grant programs to try to foster more clinicians and more professionals who come from diverse backgrounds, and that's important. I think, again, building on my earlier theme of the health system is probably the best way to scale change. We also need to look at what are the levers in the health system to advance cultural competence and diversity. Can we drill down and look through Medicare, through Medicaid, through private insurance, specifically at access in underserved urban and rural communities? Where are providers locating? Can we put in place some requirements around provider networks to make sure that we're serving people where they are and that those providers are culturally competent and diverse? So much work is being done in the health system through payment incentives. And I think that if we were to develop some standards around diversity and cultural competency, and then pay through Medicaid, through Medicare, and through commercial insurance, more to the providers that meet those requirements, more to the insurers that help advance them, then we could really move the needle.
Thank you, Vicki. Can the speakers address support for some of the more upstream protective factors for mental illness, such as decreasing poverty, helping with economic supports, and housing?
It's a long conversation, and I'm so glad it's asked, because the key is to start in on those types of interventions. So I'll just mention two that I think are pivotal. The clear observation that housing and mental health are integrated in a fundamental way suggests that the need to certainly build out supportive housing and other forms of interventions, but in a more integrated way with the kind of systems and services that can make a difference. It's striking, Avinal, as you well know, that RWJ has started to invest in the ways in which, by noting housing as one of the key social determinants of health, which is equally true in mental health, we can both, not only improve individual outcomes, but actually save and use public money more effectively. And I think there are numerous ways to expand upon that, whether it's in the kind of programs that HUD runs. I would note USDA runs a whole set of housing programs that really have not fully benefited from thinking about how they might advance mental health in the same way. So there's a whole set of housing and mental health areas. The other is around workforce. And, Vicki alluded to it, but I believe that there is a huge way in which, whether it's addressing the burnout of frontline workers and providing increasing supports to them, there's a fascinating study underway in New York City about how public housing authority employees can be trained to do triage and see when public housing families may be experiencing the onset of something in which a better intervention might be provided. And that becomes a huge value add for combining these different systems. At the end of the day, there is no replacement for education and schools as being a key element in supporting young people before they experience the onset of crisis. And again, is a key element among the panoply of interventions that are needed.
Thank you, Ken. And I have what might be our final question. How can federal policymakers support communities as they implement 988 and diversify what emergency response looks like?
I'll say a couple of things, and I'm sure Ken will want to add to this. First, I think just to illustrate the stakes of 988 implementation, 25% of people who've been shot fatally by the police have mental health issues. And so part of the potential for 988 is ensuring access, and part of it is just getting past some of the most troubling outcomes that we face as a society. And so there's real potential here. And so to the questioner's intent, supporting communities and carrying out this work is essential. Two things I would call out. One is, how do we connect people to services? The data in this is not great, but as a general rule of thumb, people generally say that about 1 in 5 callers to crisis call lines need connection to services. And most of the 988 implementation work so far has focused just on the challenge of standing up the call response. And there's good reasons for that, but we need to move beyond that to really make sure that people get connected to services. And Medicaid is a workhorse of providing crisis service coverage. But I want to come back to something that Ken said earlier when he noted that Washington State is, I believe, the first state to require commercial insurers to cover crisis services. In states that have robust crisis service continuums, they rely predominantly on Medicaid. Medicaid is the workhorse. But if we're going to create a sustainable financing structure for crisis services, we need commercial insurance and Medicare to step up and cover crisis services too. So I think we need to marry the near-term focus on 988 with commitments to expanding services through Medicaid and bringing commercial and Medicare to the table to build a more full and robust continuum.
Let me just add 2 other points, and I agree with all that Vicki said, including the key starting point, that part of the reason why 988 is important for all of its promise in terms of something much better is actually to prevent the worst outcomes that disproportionately people with mental health conditions, especially African Americans with mental health conditions, have suffered far too often in the past. The 2 things from a federal policymaking standpoint, one is to ensure that for all of the necessary focus on 988 right now, that is not viewed as the sum total of the needed intervention. 988 is a 3-digit number. It took 911 a decade to get up and running. It's going to take some time for 988 to be able to be as fully operational as it will need to be. As we do that, though, we need to ensure that the other elements of the continuum are focused upon and built out. Some of those are within the crisis continuum, someone to come, somewhere to go for the 20% who will need additional services. But some of it is to use it as the needed opportunity to really build out some of the prevention of crisis that should exist, and to see those as a collective set of interventions that can really make the difference. The other piece I would note is, especially in local communities, is to ensure that there's the kind of seed funding for some of the scaling up, especially the capital costs that are going to be needed to create some of the system components that right now are not yet in existence, and to recognize that needs to be done in the short term, but also to be built into what the longer term vision is. So those are a couple of additional things into the comments that Vicki made.
And Evan, I know we're short on time, but one thing to add is that in addition to 988, it's worth looking at 911. Just a few weeks ago, a team based at the University of Chicago released a set of recommendations around transforming 911. So if you search transform 911, you'll find them. Some of those recommendations are directed specifically at communities, and others reside at the federal level. So I really encourage your audience to take a look at them, because I think those, like 988, have the potential to help turn around some of these very troubling outcomes that we're having through police encounters.
Thank you, Vicki and Ken. We're coming to the close of our session today, and I just want to extend our deep gratitude to both of you for your insights this morning. As our speakers highlighted, the mental health burden in the United States is significant and it is growing. As with so many things, this burden falls disproportionately on communities of color and other historically marginalized groups. The mental health crisis that we as a nation find ourselves in is bleak, and solutions can seem out of reach. However, through intentional and thoughtful investment in partnership with communities, policymakers have powerful opportunities to improve health and advance equity by strengthening mental health services. I want to thank everyone who participated in this discussion today. I really appreciate your time and your interest and your dialogue. We have put the link for a brief anonymous survey in the chat. We really appreciate you completing it to help us plan for future events. We will also follow up by email with a recording of this webinar, the link to the survey, and some additional resources. Thank you and have a great afternoon.